This testing is really helpful as we're counseling our patients, but it's also really important to remember that insurance needs to cover these tests because they are expensive. So we work very closely with our financial services department to make sure that testing is covered. And that is an issue that patients can run into if their prognostic testing isn't covered by their insurance. Often we're able to write letters and say that this is clinically indicated and medically necessary, and that tends to work, but it is an important consideration. The other piece is how we do karyotype analysis. So karyotype has historically been challenging on peripheral blood in CLL cells. There are a couple of ways around that. Some people use stimulated karyotype, so you use a procedure to stimulate the cells, and it allows for easier karyotyping. There's also centers that use SNP array to kind of address this problem and get a good look at the karyotype without having to do a true karyotype analysis. Those are some of the challenges that we encounter with these prognostic tests. But in general, having a lab that you're comfortable working with to help you through these challenges is a really important piece of caring for patients with CLL.
Absolutely. I totally agree with that. And I think another point, just to build off of that, is that one thing about CLL is that a lot of this testing can be done on the peripheral blood. And so we can send, because patients have circulating disease in the blood, we can send these tests off the blood instead of a bone marrow biopsy or lymph node biopsy. Now you can send many of these tests off of the lymph node biopsy or bone marrow biopsy if it's needed for another reason, but this testing can be done from a patient's blood. The other test that I feel has entered the CLL space is minimal residual disease testing, or MRD testing. And so this is a test that also similarly can be done off the peripheral blood. And there's many different ways to do minimal residual disease testing. I would say currently, right now, it is not standard of care to do it. It's out there, so we should highlight it as something that you'll hear about. It's really being used right now in clinical trials to gather more information, and is not standard to guide treatment at this time, but maybe something that we're seeing more and more of in the future.
Absolutely, couldn't agree more. And I think in my routine clinical practice right now, I don't use MRD to guide my treatment decision making. A lot of studies have shown that outcomes at the end of fixed duration therapy are linked to MRD status, so we know that it has prognostic value, but how we should be using it to make decisions isn't totally clear yet, and these ongoing clinical trials are really going to inform that decision making with MRD testing. And just to highlight how we can do that testing, so flow cytometry is one option that's available at a lot of centers. There's also next generation sequencing availability to look for minimal residual disease. Historically, 10 to the minus 4 has been the sensitivity that we use as a cutoff to determine whether someone has minimal residual disease. But the next generation sequencing modalities are allowing us to look even deeper, so 10 to the minus 5 or 10 to the minus 6 sensitivity. So we're really getting an incredible look at whether disease is left with those modalities.